Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. Today, we have a special guest, Rupert Bartsch, from the Medical University of Vienna in Austria, who will be speaking on therapeutic options beyond ADCs in HER2-positive breast cancer.
Thank you for coming, Dr. Bartsch. So to begin, let's talk about clinical features. How do you approach patients with brain mets in HER2-positive breast cancer?
So starting with the clinical features, well, of course, there is the brain mets question. And traditionally, brain mets was something we have been treating with local therapy. But recently it was shown that systemic treatment can have great activity also in brain metastases of HER2-positive breast cancer. And the initial focus in clinical research that was with the small molecule tyrosine kinase inhibitors. And the reason for that is obviously because we have believed that the TKIs have specific activity there, because due to their molecular size, they may be able to pass the blood-brain barrier. And the latest iteration of that paradigm, of course, that's the triple combination of tucatinib, the third generation TKI, trastuzumab, and capecitabine. And we've seen large activity there. We've seen a response rate in the range of 50%, and compared with the former potential standard of capecitabine, trastuzumab, we've seen a doubling of overall survival.
Now, let's talk about ADCs for patients with brain mets. How do they compare to TKIs?
Now, more recently, we have also learned that ADCs have specific activity, and especially T-DXd. And the reason for that, again, is that at the metastatic site in the brain itself, the blood-brain barrier is partially substituted with a more permeable blood-tumor barrier. And ADCs such as trastuzumab, deruxtecan, so third generation ADCs, they have a bystander effect. And this seems to be specifically important in the context of brain metastasis, because the breakdown of the blood-brain barrier is not uniformly. So conventional cytotoxic, they have a heterogeneous uptake into the brain metastasis that is overcome by the bystander effect, and then also the interaction in between the autochthonous brain cells and the tumor cells in the brain that is targeted by the targeting of the microenvironment with the bystander effect. And that results in this extremely high response rates that we've been seeing in several phase 2 trials, DEBRA, Tuxedo 1, but also more recently in the Destiny Breast 12 trial. Now, overall, I would believe that in patients with brain metastasis, if local therapy is not indicated, second-line standard treatment is T-DXd, of course, with tucatinib being the third-line option. Of course, if prevention is the question, we come back to the tyrosine kinase inhibitors, because here it's believed that there may be some preventive properties given with small molecule tyrosine kinase inhibitors, while large molecules such as ADCs, they don't have any preventive properties at all. So this is not a proven concept at the moment, but this is something to remember perhaps. Right. So first-line standard of care is still docetaxel, trastuzumab, pertuzumab for the majority of our patients. And second line, that's T-DXd today. That may change with the ASCO meeting when the data from the Destiny Breast 09 trial will be presented. First-line T-DXd. And once patients progress on T-DXd, the evidence from prospective trials, that is really something that's really scarce. So there kind of becomes the art of oncology.
Thanks. And I guess to expand, can you maybe walk us through the current standard treatment sequence for HER2-positive metastatic breast cancer, please?
Usually we do trastuzumab, capecitabine, and tucatinib in the third-line setting, but the ESMO guidelines also suggest T-DM1 as a reasonable treatment option here. Problem is that we know after T-DXd that all the other HER2-directed treatment options, they have limited activity. So this is really a field where future research is necessary. There are many trials ongoing in the setting with novel TKIs. There are trials ongoing in the setting with biparatopic antibodies such as zanidatamab. But at the moment, our evidence what treatment to choose, that is really limited. So first of all, we need to ask ourselves the question, is the disease still HER2 positive after T-DXd? And there is some downregulation of HER2 expression in patients in the tumor in patients who progress on prior T-DXd. Then, of course, the question is this a homogeneously HER2 positive disease, or are there different clones present? So are there HER2 negative and HER2 positive clones present? And of course, over time and under treatment, the HER2 status can also change. So it makes sense to reassess this.
And I guess, what are the treatment options for T-DXd progression, and what biomarker considerations should we keep in mind after T-DXd progression?
The issue with T-DM1 is that obviously there are relevant resistance mechanisms in patients who progress on T-DXd that can relate to the heterogeneity of the disease, that can relate to the lysosomal function, so the alterations in the internalization of the antibody antigen complex and uptake not into the lysosome, but in submembranous punctae, which are basically caveolar endocytic compartments with neutral pH, so there is no degradation of the antibody, and therefore the cytotoxic is not released in the intracellular compartment. There's also the issue of rapid recycling, so rapid recycling of the early endosome to the surface, and also no lysosomal degradation of the antibody. So in the end, there are several mechanisms of resistance to T-DM1, which we have tried to overcome either with a kind of biparatopic approach, so combining T-DM1 and pertuzumab, which was not superior to T-DM1 alone in the Mariani trial. Otherwise, we could also try to stabilize the HER2 expression in the cell membrane by combining T-DM1 with a small molecule TKI, because lapatinib and tucatinib, we have the data that they stabilize HER2 expression in the cell membrane. Again, HER2 CLIMB-2 combination of tucatinib and T-DM1 only a bit superior to T-DM1 alone. So clinically highly interesting approaches, but clinically of limited activity.
And what role does HER3 expression play in treatment resistance? And what other biomarkers should we consider?
Then, of course, HER3 expression might be something that is relevant in this context. We know tumors who co-express HER2 and HER3 have poorer survival. It appears that HER3 upregulation results in resistance to HER2-directed treatment. So that is something that suggests that some biparatopic approach targeting also the heterodimerization of HER2 and HER3, which are the most potent inducers of HER2 signaling, that this might be reasonable. And then, of course, there are HER3-directed ADCs in clinical development, such as patritumab deruxtecan. ERP2 mutations are relatively rare in HER2-positive breast cancer, but they exist, and they may still be sensitive to irreversible TKIs such as daratinib and tucatinib, while there's relative resistance to lapatinib reported. Targeting PIK3CA, that hasn't been so successful in HER2-positive breast cancers.
Now, moving on, how do you approach HR-positive, HER2-positive breast cancer specifically?
So the role of pathway inhibitors, PIK3CA inhibitors, mTOR inhibitors, that is unclear. But what we have learned is that it's important in the luminal B HER2-positive subset of breast cancer to target both the estrogen receptor and HER2. And that has been successful. We've seen that the triple combination of trastuzumab endocrine therapy and the CDK4/6 inhibitor in the PATINA trial, for example, yields highly interesting progression-free survival rates of 44 months. And we also know that in pretreated patients, the triple combination of abemaciclib, fulvestrant, and trastuzumab is superior to trastuzumab and chemotherapy. So that was the MONARCH trial in the pretreated population. The problem is that these patients, of course, have not received prior T-DXd, and still, I believe, even outside of the approval for abemaciclib, this is an interesting option in the patients who progress on prior treatment if they have hormone receptor positive, HER2 positive metastatic breast cancer.
And finally, can you maybe summarize your approach to individualizing treatment and, what the future holds in this space?
So in the end, we try to individualize treatment based upon the clinical factors and the biomarkers available. TKIs and such as tucatinib and T-DM1 are an option in patients progressing on prior T-DXd but have limited activity. In the rare case of an ERP2 mutation, irreversible TKIs are preferred. And in hormone receptor positive, HER2 positive breast cancer, I believe this parallel inhibition of HER2 and the estrogen receptor is clinically relevant. And even though the CDK4/6 inhibitors are not approved in this setting, it makes perfect sense to combine the drug with CDK4/6 inhibitor to this combination if clinically possible. But in the end, all the options we have available at the moment will not solve the problem. And we need novel options in this setting because especially that T-DXd now will make it to the first line setting. So highly exciting times. We have had a massive impact on the outcome of patients with HER2 positive metastatic breast cancer with the novel treatment options. But now we need to define the best way to go on once the patient progresses on T-DXd.
Thank you to our speakers and to you for listening to this podcast.
If you enjoyed this podcast, please leave me a review and subscribe on your favourite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.